Hello everyone, I'll be presenting on IgA nephropathy. IgA nephropathy was first described in 1968 by Jean Berger when IF studies were first introduced for renal biopsy specimen. It was also called Berger's disease. IgA nephropathy is the most common cause of primary GN. Its peak incidence happens in the second and third decades of life. The ratio of male to female is 2 to 1. It is most commonly seen in Asian and Caucasian population. IgA nephropathy is a glomerular disease that is caused by increased circulating levels of IgA1 with galactose-deficient hinge region O glycans and deposition of immune complexes. These are abnormal glycosylated IgAs. Fundamental to immune complex formation is the increased synthesis of poorly glycosylated IgA1, which is known as the first hit. Genetic factors heavily influence the production of underglycosylated IgA1, and familial clustering is well recognized. However, the presence of these IgA1 O glycoforms alone is insufficient to cause IgA nephropathy. The second hit is the formation of glycan-specific IgG and IgA antibodies that recognizes the aberrantly glycosylated IgA molecules. These antibodies, often with reactivity against antigens from extrinsic microorganisms, might arise from recurrent mucosal infection, which are the subsequent hits. Emerging evidence indicates that B cells that arise in response to mucosal infection, particularly tonsillitis, may produce the nephrogenic IgA1 molecule. With increased immune complex formation and decreased clearance, IgA1, mainly polymeric in nature, binds to the glomerular mesenchyme via an unidentified receptor. Glomerular IgA1 deposit triggers the local production of cytokines and growth factors, leading to mesangial cell activation and complement activation. In IgA nephropathy, the primary cause for glomerular injury is an immune complex deposition in the mesenchyme. There's an increased amount of genetically determined circulating levels of IgA with galactose-deficient O glycans and antibodies formed against these galactose-deficient IgA. These complexes then accumulate in the glomerular mesenchyme. This process activates the mesangial cells, inducing proliferation and secretion of extracellular matrix, cytokines, and chemokines, which results in renal injury. Patients with IgA nephropathy are mostly asymptomatic. They are usually diagnosed during routine urine screening. They present with asymptomatic hematuria or proteinuria. Most cases are discovered when there is low threshold for renal biopsy. Next is rapidly progressive GN, which occurs in case of precentric IgA nephropathy and may be due to heavy glomerular hematuria which leads to tubular occlusion. It happens in elderly patients with chronic IgA nephropathy. And lastly is chronic renal failure with hypertension. These are few of the associated diseases with IgA nephropathy. Rheumatic disease and autoimmune diseases, commonly being Angst's rheumatoid arthritis and Reiter's syndrome. For gastrointestinal disease, commonly is celiac disease, hepatic disease, alcoholic and non-alcoholic liver cirrhosis, lung diseases, sarcoidosis, skin diseases, dermatitis herpetiformis, infections such as HIV, Hep B. The diagnosis of IgA nephropathy is often suspected on the basis of clinical history, but can be confirmed only by kidney biopsy with IF. A kidney biopsy is usually performed for the evaluation of suspected IgA nephropathy only if there is signs suggestive of more severe or progressive disease such as protein excretion above 0.5 to 1 gram a day, with elevated serum creatinine concentration or histologically, IgA nephropathy is characterized by diffuse proliferation of mesangial cells and matrix, hypercellular or normal glomeruli with diffuse necrotizing concentric glomerulonephritis, mesangial involvement resembling focal and segmental glomerular sclerosis. Immunofluorescence will reveal a diffuse granular pattern of IgA deposits in the mesangium. Staining with CD4 indicates a poor prognosis. Diffuse IgA deposits in the IF microscopy is the hallmark of IgA nephropathy. In 90% of the cases, you would see C3, 40% IgG and IgM. Predominantly, mesangial IgA deposits are seen in IgA nephropathy. Predominant mesangial IgG deposits are often seen in systemic lupus. Predominant IgM deposits are seen in IgM nephropathy. Mesangial C1q deposits are seen in C1q nephropathy. This slide shows the light micrograph showing mesangial proliferative glomerulonephritis. On your right is a normal glomerulus. On your left is a mesangial proliferative glomerulonephritis. On the right is a light micrography of a normal glom. There's only 1 to 2 cells per capillary tuft. The capillary lumens are open and the thickness of the glomerular capillary wall is similar to the tubular basement membranes, which is shown in the arrow. And the mesangial cells and the mesangial matrix are located in the central and the stalk regions of the tuft. While in mesangial glomerulonephritis, it shows segmental areas with increased mesangial matrix and cellularity. If you see there's multiple cells in an area, this finding can be seen in IgA nephropathy and also lupus nephritis. This is an immunofluorescence microscopy showing mesangial IgA deposits. So basically, it shows large globular mesangial IgA deposits that are diagnostic of IgA nephropathy or IgA vasculitis. So my next slide shows electron micrography. On the right side is a normal glomerulus. The normal glomerular capillary loop showing the fenestrated endothelial cell, the glomerular basement membrane, and the epithelial cell with its interdigiting foot process. The GBM is thin and there's no electron-dense deposits that are present. However, on the left side, it's of IgA nephropathy. The primary finding is electron-dense deposits that are limited to the mesangial region, which is labeled as D. The glomerular basement membrane is normal and there's no glomerular capillary wall deposits. This slide shows endocapillary hypercellularity. It is an increased number of tuft cells occluding the glomerular capillaries, and it's usually accompanied by mesangial hypercellularity. This slide here shows segmental sclerosis. It is characterized by segmental increase of glomerular matrix with obliteration of capillary lumens, and it's a common morphological features that you see in biopsies. These are the prognostic markers at presentation in IgA nephropathy. You can divide them into clinical and histopathological. So clinical poor prognosis would be indicated by hypertension, renal impairment, severity of proteinuria, hyperuricemia, gross obesity, duration of preceding symptoms, and increasing age. For histopathologically, mesangial hypercellularity, endocapillary proliferation, segmental glomerular sclerosis, tubular atrophy, interstitial fibrosis, capillary loop IgA deposits, and crescents. Good prognosis will be recurrent macroscopic hematuria. No impact on prognosis will be gender, serum IgA level, and intensity. The Oxford classification of IgA nephropathy. is developed by the International IgA Nephropathy Network in collaboration of the Renal Pathology Society. To develop this classification, clinical data, kidney biopsies were obtained from 265 Caucasian and East Asians who were followed up for a median of 5 years. Repeated analysis by several pathologists identified variables that were consistent with interpreted with high degree of reproducibility. 4 of these shown to individually predict renal outcome, independent of clinical data. Mesangial hypercellularity, endocapillary hypercellularity, segmental glomerular sclerosis, and tubular atrophy, and interstitial fibrosis. The predictive value of each of these variables appears to be similar in adults and children. It has been shown that combining MES score with clinical data at the time of biopsy provides the same predictive value as monitoring clinical data for 2 years. The utility of Oxford classification in guiding such therapies as immunosuppression remains uncertain. This is the MES-C Oxford classification of IgA nephropathy. MES stands for mesangial hypercellularity, E is for endocapillary cellularity, S is segmental glomerular sclerosis, T is tubular atrophy, and C is for crescents. In the effort to predict the risk of progression of IgA nephropathy better, this study model looked to predict 5-year risk of end-stage renal disease or 50% eGFR decline. So 2 clinical models were used, eGFR, BP, and proteinuria, clinical age, MES score, METS, and race. In this study, the 2 full prediction models were shown to be accurate and validated methods for predicting disease progression and patient risk stratification in IgA nephropathy in a multi-ethnic cohort with additional application to clinical trial design and biomarker research. Morbidity and mortality, it follows a benign course in most cases. At risk for slow progression to end-stage renal disease in approximately 15% of patients by 10 years and 20% in 20. Let's look at treatment recommendations. So these are the treatment recommendations for IgA nephropathy patients. They're divided into low risk, intermediate risk, and high risk. Patients who are low risk have isolated microhematuria or proteinuria with proteinuria of less than 0.5 grams per day, eGFR of normal, and no hypertension. They can be monitored annually or biannually for at least 10 years. For patients with intermediate risk, where proteinuria is more than 0.5 to 1 gram a day with reduced eGFR, plus or minus with hypertension, you need to optimize supportive therapy for 3 to 6 months. For those with eGFR more than 50 mL per minute, proteinuria of less than 1 gram a day, and GFR is stable, we continue supportive therapy. If you have proteinuria of more than 1 gram a day and your eGFR has declined, continue supportive therapy. Can consider adding 6 months course of corticosteroids. For eGFR of 30 to 50, you continue supportive therapy. Value of immunosuppression is unknown. Need to weigh pros and cons. For GFR less than 30, continue supportive therapy. There is no need for immunosuppression unless it's crescentic IgA nephropathy. For patients with high risk, you can divide them to nephrotic syndrome, crescentic IgA nephropathy with RPGN cause. You continue supportive therapy and consider immunosuppression. For those with AKI due to macrohematuria or other common causes, the treatment is supportive therapy. The KDIGO recommendation says long-term ACE-ARB treatment when proteinuria is more than 1 gram a day with up titration of the drug depending on blood pressure. We suggest ACE and ARB if proteinuria is between 0.5 to 1 gram a day. We suggest ACE and ARB to be uptitrated upwards as far as tolerated to achieve proteinuria of less than 1 gram a day. In IgA nephropathy, use blood pressure treatment course of 130/80 in patients with proteinuria less than 1 gram. If the proteinuria is more than 1 gram, then the ideal BP should be 125/75. Corticosteroids. We suggest patients with persistent proteinuria of more than 1 gram, despite 3 to 6 months of optimized supportive care, including ACE, ARB, and blood pressure control, and eGFR of more than 50, receive a 6 months course of corticosteroid therapy. As for immunosuppressive agents, we suggest not treating with corticosteroids combined with cyclophosphamide or azathioprine in patients with IgA nephropathy, unless there is crescent pterygium with rapid deterioration of kidney function. Here we looked at the STOP IgA nephropathy trial. So this trial includes biopsy-proven IgA nephropathy with no crescents, proteinuria of more than 0.75 grams a day, hypertension, eGFR of 30 to 90 mL per minute. There was initially a 6-month run-in phase where all patients received comprehensive supportive care with optimization of hypertension and proteinuria with the use of RAS blockade. At the end of the run-in phase trial, patients who did not respond to treatment, those who had proteinuria of 0.75 to 3.5 grams, were randomized to continued supportive care alone or supportive care with addition of immunosuppression. The immunosuppression group with eGFR of more than 59 received 1 gram of IV methylprednisolone for 3 days at the start of the month 1, 3, and 5, and oral prednisolone at the dose of 0.5 milligrams per kilogram every other day. The immunosuppression group with eGFR between 30 to 60 mL per minute received cyclophosphamide of 1.5 milligrams per kg per day for 3 months, followed by azathioprine at the dose of 1.5 milligrams per kg per day during months 4 to 36, plus oral prednisolone of 40 milligrams a day tapered to 10 milligrams a day over the first 3 months of the study, and 10 milligrams a day during months 4 to 6 and 7.5 milligrams per day during months 7 to 36. The STOP IgA trial failed to demonstrate a significant difference in proteinuria or decline in eGFR in 2 immunosuppression arms, which is steroids and cyclophosphamide or azathioprine, and there was a 35% increase in adverse events. This is the testing study, steroids for moderate IgA nephropathy. So this study ran between May 2012 and November 2015. 523 patients who had biopsy-proven IgA were recruited, and 262 were eligible and underwent randomization, 136 to methylprednisolone and 126 to placebo. The recruitment stopped early and study treatment discontinued among randomized participants owing to an excess of severe adverse events, mostly infection, in corticosteroids group. The trial was then concluded should not be continued at its current form. The testing trial showed that methylprednisolone used slowed eGFR decline and renal-related death. However, in the immunosuppression group, the immunosuppression group had an unacceptably high adverse events. As the data suggested, likely benefit on kidney outcome. A further 240 participants were randomized to methylprednisolone of 0.4 milligrams per kilogram a day compared to a matching placebo. This is called the testing low-dose group. Oral Bactrim will be also. Some patients received Bactrim for 3 months as to reduce risk of infection. All participants will undergo a long-term follow-up until at least 160 primary outcome events are observed. It's expected to be an average at least 4 years, and the effects of steroids on the risk of the composite kidney outcome will be assessed on the study population as a These are a few clinical trials done to evaluate the use of polyunsaturated fatty acids (PUFA) in patients with IgA nephropathy. Hamazaki et al. Had 20 patients with IgA nephropathy. 10 received omega-3 PUFAs in the ratio of EPA of 1.686 grams and DHA of 1 gram, while another 10 were used as controls who were not given fish oil supplements. These patients were followed up for 1 year. The clinical outcome showed the renal function improved in these patients. Alexopoulos et al. Administered very low PUFAs, 0.85 grams of EPA with 0.57 grams of DHA. A minimal dose of PUFA was equally effective in retarding deterioration in renal function among high-risk group patients with IgA nephropathy, especially in those with advanced renal disease. In a nutshell, PUFA has shown retardation of renal function decline in long term. However, no significant difference in blood pressure and proteinuria were noted. Overall, fish oil is commonly used as an adjunct given its relatively low side effect profile. These are a few studies that was done on IgA nephropathy using MMF. However, data did not show any significant difference. Hence, it was not effective for the treatment of IgA nephropathy. In the study looking at tonsillectomy as a part of a treatment of IgA nephropathy, it did not show any significant difference. Tonsillectomy may only be considered in IgA patients with recurrent tonsillitis. Recent studies looking at use of rituximab in IgA nephropathy with proteinuria and renal dysfunction has yielded negative results. Nefigant trial investigated the use of novel targeted release formulation of oral budesonide. In this randomized controlled study, patients who received budesonide had a significant reduction in urine protein creatinine ratio. The placebo group had an increased urine protein creatinine ratio. These are a few novel approaches in IgA treatment. These are a few novel approaches in IgA treatment. They target the mucosal immunity, B-cell activation, complement activation, and inflammation. This is to recap the suggested therapeutic approaches to patients with IgA nephropathy depending on clinical setting. The mass scoring system for IgA nephropathy offered the first opportunity to use histology to predict kidney outcome independent of proteinuria, BP, and eGFR. A major limitation is the absence of a validated risk prediction model that allows integration of histology with clinical predictors to establish an accurate individual prognosis. Recurrence of IgA nephropathy in transplant patients. High recurrence rate in renal transplant recipients who have IgA nephropathy, which is 25 to 60%. However, disappearance of the deposits from the donor kidney with IgA nephropathy when transplanted into donors without the disease. None of the currently available immunosuppressive drugs used after renal transplantation can prevent the histologic recurrence of IgA nephropathy. There is no clear evidence